the work we have been doing here at the Center for Multicultural Mental Health Research. And I wanted to discuss just briefly what the center is all about, because it's a center that has been operated since 2002 here at the Cambridge Health Alliance. And I also wanted to sort of show that this is a center that really focuses on how can we understand and reduce disparities and improve the access and quality of mental health services for all population, particularly for multicultural populations where there has been very little very little information and sort of service delivery directed at those populations. We actually do a lot of innovative research. I won't be talking about it today, but we do some research in terms of how can we get services to where people are, for example, telephone treatments or issues that have to do with how to get the services to community agencies that might provide in a more accessible way for communities to receive mental health care. And the other thing we do is we actually also have projects where we partner with community-based organizations to try to see if we can get build community capacity for people to have better access and better quality of services for mental health and substance abuse disorders for minority populations. So that's really what we have been doing for the last 10 years, more than 12 years actually now. And we actually do a lot of webinars and do presentations to try to get not only the information that we research, but other people's information out to the public. So today I'm going to be talking about, physical comorbidities. I'm going to start with depression, but later on I want to talk a little bit about issues that come and the importance of actually discussing this, because there's been so much interest in showing that people that have mental disorders tend to die a lot younger, sometimes 25 years younger than the general population. And there's been a lot of enigmas, what explains this phenomenon? Why are they dying so much younger? What is happening? So one of the things, for example, an area of quite a lot of importance has been depression and physical illnesses. I mean, people have repeatedly shown that mental health and physical illnesses frequently co-occur. And if we could understand the patterns of this physical illnesses that co-occur with depression, we would be in a better position to try to intervene early, to try to see how we could prevent the co-occurrence of these conditions, and if they do happen, how to treat them effectively. So one of the areas, obviously, that people have been studying for a long time is this issue about major depression, often co-occurring with physical illnesses. And I want to acknowledge the people that work on this paper. Nora Mulvaney-Day actually is a primary author of this paper, and Sean Gao also worked in this paper. So let me tell you a little bit about the objective of our study. And our study was really try to see and compare the rates of depression and self-reported chronic physical illness conditions between racial and ethnic minority populations and non-Latino whites. What we wanted to try to understand is, are the rates comparable across racial ethnic groups? And what we saw is we actually used what's called the collaborative psychiatric epidemiologic studies. And this is a big set of studies that was funded by the National Institute of Mental Health. And it actually included like 13,000 people that were surveyed in the community, in their homes, with a complete assessment. And then from that assessment, it actually asked a lot of information, not only about mental health, but also about physical illnesses and also about service delivery. And the main objectives of these studies that are combined for the analysis that I'm presenting today was really trying to understand what are the needs of different ethnic racial groups in terms of mental health, and also with respect to physical illnesses, and what do they receive right now. So one of the things that we initially thought about, that we hypothesized, is that some ethnic racial groups would have high overall rates of physical illness, because there's been some literature showing that when you ask minorities, they tend to have higher rates of physical illness than the overall non-Latino white population. But yet, despite having very relatively low rates of depression overall, because you'll see in the next slides, minorities tend to have overall lower rates of depression than the general population, but that they still would have higher rates of co-occurring depression and chronic physical illness. So initially we thought we were going to see lower rates of depression, but higher rates of co-occurrence. And let me explain the issue about co-occurrence, because I think it's a very different way of looking at illness patterns that typically is done. If you think about these two Venn diagrams, people typically talk about, for example, depression, and they talk about the population that has depression, or they talk about the population that has a chronic illness, be it cancer, asthma, whatever, and separately. But very rarely do people actually look at the intersection of those two conditions, which is what this Venn diagram is trying to present. That you should also look not only at those two separate circles, but that you should look at the intersection of depression and chronic illness. And what we see, and I'm going to show you a table now, is that what we see actually when we do that, we find, first of all, that non-Latino whites have the highest rates of 12-month depressive disorders, with 8.8% having during a year depression, and you'll see it in the table. And there's actually no significant difference for Latinos in this sample. We thought we would see lower rates for Latinos, but we don't. Or also for Afro-Caribbeans, they're actually very similar in their rates of depression to non-Latino whites. However, Asians and African Americans, we do find lower rates of depressive disorders than for non-Latino whites. And people have talked, and this is an important area, because there's the belief that in certain minority populations, depression is higher, but actually for both Asians and African Americans, we find that the case is the opposite. It's lower. So looking at rates of physical disorders, we also find that the patterns are very different across racial and ethnic groups, and that depending on the disorder, you find that it's higher for certain groups and lower for others. Let me show you this now more extensively. So for example, the first thing I want to show you is what I was talking about. Whites and Latinos have very similar rates of 12 months depression. Asians and African Americans much lower rates, with 4.3% for Asians and 6.2% for African Americans. And then for Afro-Caribbeans, you see again also very similar rates to the whites. Chronic pain, and I want to really emphasize this, because chronic pain is actually quite high for all groups you see here. It's actually particularly high for African Americans, with 31.6% reporting chronic pain and 31.4% of Afro-Caribbeans presenting chronic pain. But again, it's very high, 27.8% for whites, 25% for Latinos, and even 21.2% for Asians. So chronic pain is actually quite high for all populations. Cardiovascular disease, you see here that it's substantially higher for African Americans and Afro-Caribbeans compared to whites, which are only 26.5% reporting cardiovascular disease. We see African Americans and Afro-Caribbeans with substantially higher numbers. And then if you look at diabetes, I want to also point to diabetes. You see much lower rates in the white population, higher rates for both Latino and African Americans with diabetes. And the other surprising thing is you see in terms of other chronic conditions, and this has like cancer, things like that would be higher overall for the non-Latino white population. Let me tell you a little bit about really interested about. And what we find in the intersection is that Afro-Caribbeans and African Americans with depression. So now these are people that have physical disorders in people that already fulfill criteria for depression. And what we see is that for both Afro-Caribbean and African Americans with depression, they have higher proportions of cardiovascular disease than the white population. Substantially higher, almost 2 to 1, more cardiovascular disorders among the depressed Afro-Caribbean and African Americans. With Latinos, what we see is that's not the pattern. The pattern is more the Latinos with depression have higher proportions of diabetes than non-Latino whites. Again, almost a 2 to 1 example. And then for Asians, despite showing significantly lower rates of depression and chronic illness, if you saw in the first table, those with depression, there's really no difference in the co-occurrence of physical illness as compared to whites. Only for asthma and lung disorder are they different. So let me show you this table because I think it will show exactly what I'm saying. So first of all, look at chronic pain and depression because it's very, very prevalent across people that have, across everyone that has depression. It's very prevalent to have chronic pain. So you can see it co-occurs quite high for all white, Latino, Asian, African American, and Afro-Caribbean groups. But then when you go to, for example, cardiovascular disease, you see that the rates are higher for African Americans and Afro-Caribbean. And then when you look at diabetes, you see it's higher for the Latinos, while severe illnesses is pretty much across the board for everyone. But again, I want you to focus, one, on chronic pain being very prevalent, and two, on the importance of different patterns of co-occurring physical disorder depending the ethnic racial background of the person. Cardiovascular disease more prevalent among the depressed African Americans and Afro-Caribbeans, and then diabetes more prevalent among the depressed Latinos. So what this information tells us, and I'm going to cover two areas here. One is that, you know, there's been a lot of quality care initiatives that have focused, you know, on being universalistic, on trying to improve care for everyone in the same way. And what we see here is there's evidence of both initiatives should happen. So for example, it's important of thinking about initiatives that include, you know, pain and depression for all the population, because as you could see from these tables, it seems to happen quite frequently, the co-occurrence of pain and depression in all populations. And it would suggest that, yes, we should be having universalistic approaches to serving people with depression, with also ways of managing chronic pain. On the other hand, our findings also suggest that we should be more targeted and do more specific programs that coordinate depression care for African Americans and Afro-Caribbeans with cardiovascular disease, that maybe we should try to focus on those two co-occurrence, depression and cardiovascular disease, for the African American and Afro-Caribbean. And for Latinos, we should target programs that try to deal more with depression and diabetes. Because we know that depression leads to worse outcomes among those with diabetes. And Latinos seem to have a higher risk of diabetes complications, and they actually have worse outcomes for diabetes. This is a targeted opportunity to offer something that combines both depression and diabetes care and management. So we should be including some modules of management for the Latino population that work with both conditions. We also know that Latinos tend to prefer to be treated by psychotherapy and less by antidepressant medications. And maybe having an integrated approach that sort of covers both the mental and physical health would be very important here. And as I said, we might want to try to think for African Americans, given that they seem to have more the pattern of depression and cardiovascular disease. How can we try to deal with stress? Because stress seems to exacerbate both depression and cardiovascular disease. So having, the possibility of stress management more directed at African Americans and Afro-Caribbean populations, especially issues that have to do with the experience of racism and active coping, would be more helpful for this population and should be an area of intervention. The second area that I wanted to talk a little bit about has to do more with what we were interested in, like I say, trying to understand what people that have actually comorbid conditions, could we try to understand, why they go less to treatment? So there's been a lot of literature. Actually, the Agency for Health Quality, Health Research and Quality, AHRQ, has done a series of disparities reports showing that both Latinos and African Americans are half as likely to receive care as non-Latino whites. Even when they have the same clinical profile and they look very similar, they are only half as likely to get to care. And so we're interested in trying to find out what are the mechanisms that try to explain why there's this service disparity. What's happening? So for example, we were interested in understanding, we've been looking at language barriers, insurance, and other possible mechanisms. But now we wanted to look at specifically things that have to do with comorbid physical health conditions, and whether having a physical health condition could lead you to be identified and treated for mental health in a faster way. So here what we were trying to see is, there is some literature, again, that both Blacks and Latinos have more chronic conditions. And that there was some literature suggesting that when you have a chronic condition, you're more likely to get treated. So what we hypothesize is that comorbidities could have two types of effects. One effect is that if you had a chronic physical condition, because you are trying to, in your visits with your provider, trying to explain all your physical illnesses, it would leave no time for discussing your mental health conditions. And that's what we have called crowd out. It means that because you're spending the time trying to deal with a very complex situation, the provider wouldn't have enough time or wouldn't put enough effort in trying to figure out what's happening of two conditions, but we focus more on the physical condition, leaving no time for discussion of mental health, which would make you less likely to actually be identified with having mental health condition. Exposure, the other alternative that we thought about was that when people actually go to the doctor on many occasions, it is more likely that their doctor might get to know them, might get to be able to identify they're having a mental health problem. So that's what we wanted to try to see, and I can explain to more. What we actually found is that contrary to what we thought, across the 31st days of treatment, for people that actually did first, second, or third primary care visit, actually there was no difference in being identified and starting mental health care at all if you had a comorbidity. So there was no sort of, we didn't show any difference for people that had comorbidities in terms of the crowd out effect. That is, the providers were not more likely or less likely to identify a mental health condition. What we did find is, yes, if you were more likely to go to have more physical health visits, you were more likely to start initiating mental health care very quickly. So it didn't make a difference if you went more to the doctor in terms of being identified and getting treated early on for a mental health condition. So it is true that people with multiple comorbidities have more of a chance of being identified and referred for care. So the other thing we found is that there are differences in initiation of mental health treatment, both between Blacks and Latinos compared to whites. So for example, in this pattern, what we found in this study is that 18% of whites that went to physical visits were more likely to be referred to treatment, compared to only 9% of Blacks and only 8% of Latinos. So there seems to be quite a difference in terms of who's going to get to care, even in the same situation of of exposure. So although anyone that actually goes more to the primary care physician is likely to get identified and treated for their condition, it is substantially higher among the white population than it is among Blacks or Latinos. And one of the things we wanted to know is whether this has to do with the Latinos or African Americans being more sick. And when you're more sick with a physical condition, you're more likely to get just treated for that. But what we found is no, even when we adjusted for the level of comorbidities, it actually didn't change. It didn't change that either Blacks or Latinos would be going less. The same thing happened for the Latino-white disparities. It remained pretty much the same, with very low rates of Latinos getting treatment for mental health or substance abuse, even seeing their primary care provider. But everyone got more likely to be detected and treated if they went more to their primary care provider. So overall, what we're finding is that there must be system variables that are really explaining why Blacks and Latinos, even though they go more to the primary care providers, they're less likely to get treated for their mental health and substance abuse if they have co-occurring conditions. So I think this is an important finding. What it really tells us is, that although it's true that there might be a little more crowded for Blacks and Latinos with multiple comorbidities, it still doesn't explain that they are not less likely to get identified because of that. So it's really the exposure to more, making sure that you go to your primary care visits to get you identified. I also want to now take advantage before I end, to tell you a little bit about what we're trying to do to try to deal with these comorbidities. And one of the things we're trying doing in dealing with these comorbidities is trying to see if we could do what's called patient activation and self-management, because we think that the more you can actually do with respect to having a role and advocating for what you want out of care, that this is where it changes completely the interaction between the provider and the patient. So what we've been doing is what's called the DECIDE intervention. This is a patient activation intervention, and what we tested is whether we could see if we could actually help patients become more activated about their care, to make sure that they get their agenda covered during their visits rather than the provider's agenda. And this is an intervention that's very simple intervention. It consists of 3 45 minutes. It's a psychoeducational session that's delivered by a care manager. And the objective of this psychoeducation is really to help patients formulate and ask questions to their providers to improve their mental health care, and again, achieve what they want, to make decisions about their care during their visits. One of the things we found when we were doing initially some of this work is that patients would tell us they didn't have a lot of options, and because they didn't have a lot of options of care, once they got a provider, if the provider was not really accommodating or was not flexible, or they didn't like certain things about the provider, it was more likely like they would drop out of care rather than negotiate what they wanted out of care. So in a certain way, because there's a limited supply of providers, we were very concerned that people were dropping out of care rather than getting the care that they wanted and deserved. So this is sort of the purpose of this intervention. The DECIDA training, what we try to do it's like I said, 3 trainings. And in the first training, we try to focus on the importance of asking questions. Why asking questions? It really changes the dynamic with your provider. It's amazing because by asking questions, you can brainstorm what are the issues that are important for you to discuss in care. How could you then ask about issues that are important for you, both in asking open-ended and closed-ended questions? So we cover a lot of times, if you were discussing with your provider, what would you want to discuss? What are the issues? What are the problems that are more central to you? Do a brainstorm of those problems and don't even think about it. Just write them up. And then try to think what questions could you ask regarding those problems, and then how could you prioritize them. In the second session of the DECIDA training, we actually spend more time discussing the who, the how, and the why of questions, how different types of questions lead to different types of information for you, and how having different questions in the session can tell you, for example, who is having a role in the decision making. Is it a decision of your provider, or is it a decision that you want to have, or is it a joint decision? Or the how, why, for example, how is your provider making decisions about your medication, or how is your provider deciding that you should cope, you should deal with this in this way, or how did they reach a diagnosis? While the why is really more like what's happening behind a decision about their care. Why is the provider deciding this dose versus that dose? Why this medication? Or why are we doing cognitive restructuring? Why are we not trying, interpersonal therapy? Or so it gives you a lot of determinations of how to find about your care, and this could be translated to many things in life. It doesn't have to be only about your care. And then the third training really focuses more on the importance of self-management of your illness and how people can really take over a decision about self-management, because actually sessions with providers is very limited in terms of time. So having more of a say in self-management, knowing more about the condition, about triggers, about what are coping skills that are important, how to deal with emergencies, it really helps empower, one in terms of how to deal with obstacles. So that's the other thing. What we found in doing this training, we did it in 13 clinics across the United States. And we found that we definitely could improve patient activation and self-management, that people could do a remarkable job in sort of increasing both their activation and self-management in care. And it really changed the dynamic. However, what we found is that providers were not necessarily very happy with the intervention. They felt that in a certain sense, it really changed the balance between the patient and the provider. And now we're actually going forward and trying to see, can we do an intervention with providers to be more receptive to what we call shared decision making, so that patients and providers in a certain way share more of the journey of mental health care. And I'm going to stop there because I want to make sure that I have a lot of time for questions, and I'm happy to make sure that I cover it. I want to just briefly talk 2 slides of recommendations. I think one of the things is you're going to see that I'm very pro patient activation and self-management, because I think it's an important aspect of taking over part of your care. And then I do think that there should be universal programs that help with chronic pain and depression. But I also think there should be tailored programs for particular illness patterns for certain ethnic racial groups, and that people should try to visit more and keep their appointments with their PCPs, with their primary care providers, because this is where I think we can try to create a bond with our providers and really establish more of an alliance in our treatment process. So thanks so much, everyone, and I'm open to questions.
Thank you so much. We really appreciate your time and sharing all the information and all the work that you guys are doing. If you guys have any questions, there is a questions box and we will start to ask them. So going back to your last slide, when you talked about studying the universal programs, are there any that currently exist?
Yes, actually, there have been chronic programs that have been done in cardiovascular disease and depression, and there's others that have been done on diabetes and depression. There's not a lot of universal programs that are put in place. Kaiser Permanente has several that they've done, but there's not a lot.
Okay, thank you. And then for any of the studies that you are currently doing, are you guys recruiting any type of participants?
We are. We are currently in Boston, actually doing a study on trying to improve, again, how I said, the patient-provider interaction and more of the shared decision making, and making sure can we train both, can we coach providers to actually be more patient-centered. And so for that, we're actually running a trial here in the Massachusetts area where we are actually recruiting both patients and providers and trying to, again, do the SIDA intervention and helping coach patients how to do more of their agenda in treatment, and coaching providers to be more receptive to the importance of a shared decision making for care. So yes, we are.
Okay, thank you. And do you have a link that we can share?
I would be glad to. I'll try to put it in our website. Right now we don't, but if you go to PCORI in our website, which is www.multiculturalmentalhealth.org,
Okay.
and you look in within our website, the PCORI study, it really explains it. And
Thank
this is
you.
a patient-centered outcome research initiative.
Okay. Our next question, I think, goes back to one of your earlier slides, but why did you exclude Latino whites? The Latino ethnic population includes both and non-whites.
No, I'm sorry. I'm really glad that it was raised. So we're using the census categories of how the census makes decisions. And what we did is, independently of the race of the Latinos, they would be grouped under Latinos. So it's not that we're excluding Latino whites. It's actually all, once you identify your ethnicity as Latino, that tends to override your race. And so everyone's grouped as Latino if that's one of the categories that they say, independently of their race. So it's not that we excluded Latino whites.
Thank you. Our next question is, are there any opportunities planned in the Western New York region or UB Medical School?
Yes, we actually have two proposals that we put, and they are going. We're actually putting a proposal that includes Washington State, and then we have a proposal that includes New York. So it really depends on the opportunities we have with collaborators. But if people are interested, they can write to our website or write to me, and I am definitely I would be interested in linking people to other opportunities.
Wonderful. Do we have any more questions? A comment from the last question was, thank you very much for answering that. Okay, and are you able to provide your contact information in case anyone has personal questions that they would like to send to you?
Sure. My email is malegria at CHA research, altogether, charesearch.org. So people can, if they have any questions they will want to do or ask me, I'm happy to, you know.
Thank you so much. We really appreciate it. And thank you everyone for joining us. We appreciate all the time you took today.
Oh, not a problem at all. Thanks so much, Debbie. Thanks so much.